It's great to be here for the first of this new idea of a series that sort of mimics departmental grand rounds. Is sort of the idea where we are going to try to bring together the community around really important topics when we have the opportunity to have really important speakers to share with the community. And so welcome. And I'm really excited for today because today I have the distinct honor of introducing not only an amazing scientist and an incredible leader, but also a very long-time collaborator and, more importantly, a really good friend, Dr. Tahmeed Ahmed, who has been working at icddr for many decades and is currently the executive director of icddr in Bangladesh. He has worked for his career in simplifying the management of childhood malnutrition, childhood tuberculosis, and diarrheal diseases. He received his medical degree and then did residential training in Dhaka and subsequently studied in Japan, where he did his PhD. He serves as a member of the Nutrition Guidance Expert Advisory Group at WHO. He's been involved in revising global guidelines for the management of childhood acute malnutrition. He serves on the Global Task Force for Cholera Case Control. Dr. Ahmed was awarded the Bangladesh Academy of Science, Dr. Sultan Ahmed Chowdhury Gold Medal for outstanding achievement in medical science as well. He's also received from the Honorable Prime Minister of Bangladesh, the prior Prime Minister of Bangladesh, the Islamic Bank Development Transformers Roadshow Award. He works closely with the ministry, of course, in Bangladesh, but also with a number of multilateral organizations, including WHO, UNICEF, and others. He was the president of the Commonwealth Association of Pediatric Gastroenterology and Nutrition, and is a professor at the James P. Grant School of Public Health, Brack University, and also an affiliate professor at the Department of Global Health at the University of Washington, where I had worked with him previously. And so lots of accolades, lots of titles, but most importantly, I think Tahmeed has really, I think, taught me personally and taught many of my colleagues how to really engage in meaningful partnership and to do it in a really thoughtful and constructive way. And I really value that he took the time to be here today and to speak with us about childhood malnutrition. So with that, I welcome Dr. Tahmeed Ahmed.
Thank you, Dr. Walson, for the very generous introduction. This is my first visit to this school. I've been to Baltimore, but not to the school. And I'm really humbled when I found out that I would be speaking to you at this summer hall. And when I entered the hall, I saw this portrait. You know, somebody whom I regard so much for his work on vitamin A. When I started my career, you know, I had to take care of children with eyes simply melting down. It was so frustrating on a day-to-day basis. But it's because of this vitamin A supplementation program in Bangladesh, as well as in other countries, we don't see that so much. We don't see what is called keratomalacia, although we do still have subclinical vitamin A deficiency. But today, ladies and gentlemen, I'm going to talk about childhood malnutrition, the search for solutions. I'm going to dabble a lot on health systems. It is because of the fragile health systems that we have this problem as a scourge, not just for children, but for mankind. But again, Dr. Walson, thank you very much for giving me this opportunity to speak to all of you. But before I start my talk, I want to talk a little bit about the place where I come from. And again, and this is icddr. For those of you who don't know about this place, this is a very strange acronym, and it stands for International Center for Diarrheal Disease Research. And there's a comma, Bangladesh. And this is started in the year 1960 primarily to find out a remedy for cholera and other deadly diarrheal diseases. This is the place where most of the research was done that led to the development of oral rehydration salt solution. And I'm so proud to tell you that today, as per an estimate, ORS has saved the lives of 70 million people all over the world. So this is a gift not just from icddrb, but from Bangladesh to the rest of the world. And today, as we stand, we not only take care of diarrheal diseases, we deal with any problem that is of a consequence to people living in low and middle income countries. So it was established in 1960, and till today, we had 15 directors of icddrb. Out of these 15 directors, 12 were American nationals. And of these 12 nationals, there are 5 who happen to be directly or indirectly associated with this very august institution, Johns Hopkins University. And I'm so glad that I have 2 of my directors, my bosses, who are sitting in the audience. Dr. Greeno, when I first joined icddrb, Dr. Greeno, he left icddrb and then came in after Greeno, after several directors, we had Dr. David Sack. And not just 2 of them here, I can also see here Dr. Robert Black, who happens to be the chair of the scientific advisory group of icddrb. Dr. Abdullah Baki, who was our colleague, our senior colleague at icddrb, rising from the fields, research fields of MATLAB, and now he's a professor here. What a pride for all of us Bangladeshi researchers working at icddrb. And not just, Abdullah Baki Bhai, Parul Christian, and then we have Keith West, we have Peter Winch. I can go on, name all of them who have worked at icddrb. And it is because of their work today, icddrb stands very tall, and we can do all the research for humanity across the world. Thank you very much. So what I would do over the next 35 minutes or so is I'll talk about the burden of childhood malnutrition in Bangladesh. Why does it persist? Bangladesh has made so many important strides, but why would malnutrition be still a major problem in this country? I'll talk about that. And then I will tell you about this search for solutions and 2 solutions that we at icddrb have developed. One is the local ready-to-use therapeutic food. We call it Sharnali. And the other is the microbiota-directed food. And then finally, I will again go back to health system, because it is the health system what matters and what our plans are to address the issues related to health system. These are 2 young boys. Both of them are 8 years. And they are living in Mirpur, where we do most of our work related to malnutrition. Right in the middle of Dhaka city. And you can see one of them, the smaller guy, he is 8 years, but he is so short. And this is what stunting is. And we know that stunting is associated with excess illness, increased risk of death, poor response to vaccines, particularly the orally administered vaccines. And of course, we have found through MRI studies that stunting is associated with poor development of the brain. And you can imagine the future that lies for this young gentleman. And then on the other hand, if you look at this slide, the photographs tells you everything. A very young mother, hardly 17 years old, and she is holding her child, again, 8 months old. You don't have to measure, do the anthropometry. Just look at the child and you will understand how extremely wasted the child is. And today, we have done the research at icddrb, and we have found that it is related also to the damage to the intestines, a condition called enteropathy, which is so rampant in countries like Bangladesh. Today, as I talk to you, there are about 150 million children suffering from stunting, about 48 million children suffering from wasting or acute malnutrition. Many a times I hear that it is Africa where you have most of the burden of childhood malnutrition. It is not. If you look at the total number of children, 52% of children who are affected by stunting, they are in Asia, and most of them in South Asia, in Bangladesh, India, Pakistan, Nepal, Afghanistan, so on and so forth. And if you look at the number of children who are wasting, again, you can see the wide variation. 70% of them, they live in countries in South Asia, while 1/3 in sub-Saharan Africa. So the hub of malnutrition, childhood malnutrition, happens to be in Asia, South Asia, and I always consider this to be an orphan because so little attention is being paid to by the national governments. And this is what is happening in Bangladesh. And this is from 2011, the Demographic Health Surveys. And you can see that there has been improvement, but despite that, we still have 11% of children who are suffering from wasting because of the food price hike. And this is what we have seen from smaller studies, that this 11% has increased in some places to 17%. If I do an average, we'll be very close to 15%, which is the WHO threshold for calling it an emergency. So Bangladesh is on the brink of being at an emergency if we consider this acute malnutrition. Stunting is down to 24%, but even then, 1 in 4 children suffers from stunting. And if you look at the numbers, today we have about 1.7 million children under the age of 5 who are suffering from wasting, and about 300,000 children who are suffering from severe acute malnutrition. And these children are at extreme risk of death. And these are the districts. If you have been to Bangladesh, if you recognize the districts, most of the districts which are plagued with high levels of malnutrition happen to be in the north, in the east, and in the south. There are several challenges. And the first challenge that I see is that if you start treating acute malnutrition, you will be successful. But in many cases, the results will be short-lived. The effect of treatment may not be long-lasting. And when we speak about this 150 million children suffering from stunting, there is no specific treatment for stunting at all. And the number 3, as I spoke to you, there is gut dysbiosis, an abnormal gut microbiome. And this is one of the root causes of the problem, which has not been addressed hitherto. Now, those were the general challenges. Bangladesh has some additional unique challenges. Huge burden, and yet virtually no treatment available, neither for stunting nor for wasting. If you look at the government books, it tells you that, yes, we have these facilities available. When you go to the field, you will find none. So virtually there happens to be no treatment available. Rural areas, they have community clinics and sub-district hospitals. In principle, very good. And this is what I and many of my colleagues believes should be the cornerstone of primary healthcare in Bangladesh. But I'm going to tell you what is happening. In urban areas, in the city of Dhaka, in Chittagong, in Khulna, it is even more precarious. Precarious because there is no health care for people living in slum settlements. It falls in the crack between Ministry of Health and Ministry of Local Government. Local government says that health is our issue. Ministry of Health says that no, it is ours. And in the end, nothing is happening. And this is the fiasco that we have been observing over the last 2 decades. Something has to be done. The third challenge is, for acute malnutrition, for these children, the government says that it has these wards in major hospitals, but it imports the WHO specified this liquid formula, which is known as F75, F100. Mind it, the government has to import this from other countries, but it does not import ready-to-use therapeutic, which is the cornerstone of community-based management of acute malnutrition. Why? Because the government does not endorse it, and there was a huge sensitivity when we started this work on this. Again, a major health system issue. Sensitivity because people thought that it is going to have an adverse effect on breastfeeding. It is going to promote overweight, and it's an alien product. It has to be imported. All of these are, not true. And that is why we thought that we should do some work on this. Before I go into that, I'm going to talk again about the part of the health systems. Community clinics. In rural Bangladesh, there is one community clinic for about 10 to 15,000 population. And the population, the people, they donate the land and the government builds the infrastructure, provides what we call the community healthcare provider who runs all the medical treatment as a paramedic. A couple of months ago, I happened to visit Kurigram up in the north, okay? My primary objective was to have a real hands-on, look at what is happening. And, I'm sorry, you are seeing me on both the photographs. I couldn't help it. On the left side, this is a community clinic. When we went there, it was closed, almost abandoned. I think I went to 5 or 6 community clinics. Most of them were closed because the government cannot provide this salary to the community healthcare provider. Again, it's a fiasco. They are now running on what we call the development budget, but they would like to be in the revenue budget, sort of permanent positions. And now they are in a fix. As a result, they are not getting paid and they are not coming to the office. So the community clinic is closed. In one of the community clinics, this is on the left side, you can see there's a community healthcare provider. He's still working. And when I asked him, why do you come? Nobody is working. He said that, look, this is my area. So I have a sense of responsibility. I have got nothing to do, and I have my fields and other things that can manage me to live, maintain my livelihood. That's why I come and help people. So this is what is the condition in Bangladesh right now. But a silver lining is that the current government is taking some steps so there can be rehabilitation of these community clinics. We then went to the district hospital, the major hospital, particularly to see what happens when a child is taken by the parents for the treatment of severe acute malnutrition. This is inside the ward, the malnutrition ward. There were no children. And when I wanted to look at the statistics, so the last 1 month, there had been no patient admitted there for severe acute malnutrition. You can see I can holding these containers. These containers are imported F75, F100 from another country. Fortunate that this ward has access to this. Many of the hospitals, they don't even have this. So that's why they ask the patients, the caregivers to buy the milk and other things. And that's one of the reasons why they don't want to stay in these hospitals. So that's the health system, the burden of childhood malnutrition in a country like Bangladesh. Let me now talk about this solution. The first solution is the development of local, ready-to-use therapeutic food. Back in 2004, I guess, there was a workshop organized by the government of Bangladesh where we said that, yes, the country needs RUTF, but it has to be locally developed, it has to be locally produced. And this is what we have been able to do over the last very many years. There are 2 varieties of RUTF that we produced. One is made of rice lentils because Bangladeshis, they simply can't live without rice lentils. We thought that this would be a good idea. And the second is made of chickpeas, which is a very healthy food. Other food ingredients include milk powder, sugar, oil, and of course, you have the micronutrient mix. So over the years, we have developed and fine-tuned this, and now this is being made by a Bangladeshi company, Care Nutrition Limited. You can see the sachets of this therapeutic food, a very 100-gram sachet that contains RUTF, and that gives you 500 kilocalories. So very energy-dense food this is, and this is for the treatment of severe acute malnutrition. To fast forward, we came across a huge degree of sensitivity, so much so that I appeared in local newspapers. There were comments about us, against us. We are not even allowed to speak in public forums about this. But finally, we overcame this, and several years ago, we prevailed on the government of Bangladesh to allow us to do this effectiveness trial among Rohingya children suffering from severe acute malnutrition. Why Rohingya? Is it because they are refugees? No. The answer is the government did allow UNICEF and UNHCR to import RUTF for Rohingya children only. So we thought that, okay, this is a homegrown product. Why don't you allow us to test this? If this works well, then you are going to save foreign exchange. We can use this at least among Rohingya children. So this is the approval that we got. But before that, several years ago, we did this efficacy trial comparing this local RUTF Shornali with the traditional, prototype plumpy nut. So in the effectiveness trial, we did this on 6 to 59 months old children suffering from SAM. This was a community-based effectiveness trial. The total sample size was about 450 children. Now some photographs. This is one of the, camps in Cox's Bazar, Rohingya. This is one such child, another child being measured. This is the MUAC tape, which we use to identify children suffering from severe acute malnutrition, again, inside the camp. And this is what you see, a child taking the Shornali 1, just taking it from the sachet itself. So again, to fast forward, this is the outcome we compared. Since we had done the efficacy trial, we thought that it's no longer important to compare again with plumpy nut. So we had this comparison between rice, lentil, and chickpea based, and you can see recovery, non-recovery, defaulter rate, dropout, and deaths. There was no difference. And acceptability-wise, this was very much acceptable by the population. We also looked at days to recovery, very much comparable with programs in Bangladesh. Elsewhere, we don't have any program in Bangladesh. And again, you can see that there was no difference between the two foods that have been developed and tested. I'm now going to talk briefly about the second solution today. And this is the microbiota-directed complementary food. So before I go on to talk about this, this is what we found from children who are healthy living in slums of Mirpur and depicted by the red, very bright colored columns on the right side. This is a heat map which tells you about the composition of the gut microbiota. This was 16S sequencing that was done on stool samples. You can see that compared to this bright, heat map depicting children who are healthy, the other two series of columns happen to be from children who are suffering from severe acute malnutrition and who were treated in the hospital run by icddr. This was many years ago. And you can see there's a stark difference, all dark and drab, which means that the gut microbiome of children suffering from SAM is immature, it's not fully developed. When you compare these children, a 6-month-old child with SAM will have a gut microbiome which is similar to a 3-month-old healthy child coming from the same socioeconomic setting. So we found out that, yes, the gut microbiome was at fault. We then thought that whether this is a cause or an effect. For that, we took the diet that these children, healthy children living in slums of Dhaka city, we took the gut microbiota of children who are healthy and who are suffering from severe acute malnutrition to the notobiotic lab of Dr. Jeffrey Gordon at Washington University. Notobiotic lab is a lab where you have animals who are born and reared in absolutely germ-free conditions. We gave the food to two groups of mice, and both the groups of mice received the gut microbiota transplant. One received the transplant from healthy children from slums of Dhaka city. The other group received the gut microbiome of children whom we treated at the Dhaka Hospital of icddr suffering from severe acute malnutrition. The red line indicates the weight of mice who received the healthy gut microbiota transplant, and you can see that the weight is static. On the other hand, the green line depicts mice who were given the gut microbiota transplant from children suffering from severe acute malnutrition. And you can see that there was a drastic fall in the weight of these mice. And that indicated that perhaps it is the gut microbiome that is at fault. Based on this knowledge, we then went on to think that how we can rescue this. One option could be to give the child a dose of the proper gut microbiome. But when you go on to do it, that was an ethical and a moral issue. You have to tell the mom that, look, the source of this is human poop. Nobody would agree. We then thought that, okay, human beings require food for sustenance, so do bacteria. So let's then think about a food-based approach. So we then again did bit of nutritional anthropology. We tried to find out what are the foods that children who are healthy but live in slums of Dhaka city consume. We thought that there must be something in this food. So we took this food and we prepared a number of recipes and we called them microbiota-directed complementary food recipes. And you can see the different permutations and combinations here, starting from green banana, chickpeas, potato, red lentils, sweet pumpkin, tilapia fish. Back in the lab of Jeffrey Gordon, we did these experiments again, giving these foods to the mice. And here you can see a correlation matrix. The red colored cells indicate a very good correlation, and you can see a very good correlation happening with tilapia fish, chickpea, green banana, and then peanuts, with all the very good members of the gut microbiota. Some of them happen to be Doria longicatena, and then we have Faecalibacterium prausniesii. So we now know what the good food ingredients are and who the good bugs are in the intestines of children. We thought that we should do a trial. So we tried to do a pilot just to see what happens. So we had 3 important MDCF formulations, 1, 2, and 3, and we tested it with something that we had developed earlier, which is called ready-to-use supplementary food, which is based on rice and lentils. And this is MDCF2, and you can look at the composition: chickpea flour, soybean flour, peanut paste, green banana powder. Initially, we started with mash, the pulp, but then we found out that the powder was better. Soybean oil, sugar, and of course, the micronutrients. And you can see the mom giving the child a dose of this MDCF. This is right in the middle of a slum in Dhaka city. And again, the food preparation laboratory, this was also established right in the middle of this slum where we had this food prepared to be given to these children. So based on the results of the pilot study, this was only on 60 children, we found that yes, there was a repair of the gut microbiota, there was promotion of weight gain, plasma biomarkers, they increased, and there was mediation of healthy growth. Bone formation was quite prominent, as well as the markers of CNS development, brain development, were very prominent among those who received one particular MDCF, which is MDCF2. This is the thing that I just showed. Minded that this MDCF2 did not include milk. Milk in developing countries happens to be one of the most expensive commodities. Therefore, it was a deliberate intention to not keep milk as a component of this MDCF. Very busy slide, but this is just to show you that we looked at the plasma proteins. This is through somologic scan. You just have, excuse me, you just have 100 microliters, and that can give you an idea of 5,000 plasma proteins. In the middle, you can see SPP1, marked in a red rectangle. This is osteopontin 1. This is a marker of development of long bones. If a child has to grow, first of all, the long bones also have to grow. And we have seen that this SPP1 was more marked among children who received MDCF2. Likewise, we saw a similar result with many proteins that positively affected development of the brain as well as immune competence. So with this, we thought that we should do a regular trial, and a number of trials by now have been done. This trial I'm talking about was done in Kurigram, which has a very high rate of malnutrition, as well as Dhaka city. And we had, objectives again, promotion of the repair of microbiota immaturity, proliferation of the beneficial bacteria, and of course, both ponderal and linear growth in children, and then, of course, improving the metabolome of children suffering from moderate acute malnutrition. Again, I won't trouble you with going through this slide, but suffice it to say that these were children with moderate acute malnutrition, 12 to 18 months old, and there were two arms. The first arm was this microbiota-directed complementary food, and then the second arm, children received rice, lentil-based, ready-to-use supplementary food. These were given for a period of 3 months, and then they were followed for a longer period of time. And this is a picture from Mirpur, which is not far from icddr. What we found from this regular trial was, again, a replication of the pilot trial. There was a repair in the immature microbiota, weight gain, and plasma biomarkers related to bone formation, neurodevelopment, and immune function. And this was published in the New England Journal of Medicine a couple of years ago. What you see here is the differential in growth. The blue line depicts children who received this MDCF2 for a period of 3 months. And you can see the effect size, the change in difference, 0.011, which means that if you give children this diet over a long period, you are going to have an effect size of, a standard deviation of 0.5. So in nutrition, this means a huge impact. So we have seen that children who received this MDCF2, they recovered well, and that was sustained. But we are not happy. We are not happy because we wanted to see an improvement in length, but we didn't see just after 3 months of treatment. But we kept following these children over the next 2 years. After 2 years, we were surprised. We found that now there was an impact on length. The linear growth significantly improved in children who received MDCF2 compared to children who received the control, the RUSF. We also looked at, the microbiome, and we found that all the good members of the gut microbiota, they were positively correlated with weight for length Z-score, and of course, in children who received MDCF2. You might have the question now in your mind, how does microbiota-directed food work? What is the mechanism of action? Well, so we did a number of studies. First of all, we tried to find out what's happening to the gut microbiome. In this volcano plot, you will see that, members of the gut microbiota, such as Agathobacter, Blauschia, Faecalibacterium, and of course, the new kid in town, Prevotella, they are associated positively with weight for length Z-score, meaning ponderal growth. We then went on to look at the composition of MDCF2 and ready-to-use supplementary food. This is the work that we did with Carlito Labrilla at UC Davis. You can see this is a complex slide. On the left hand, you can see MDCF2 had less starch, it had less cellulose, but it had significantly more glycans. Glycans, when you break down carbohydrates, you get glycans. And it is the glycans, not the protein, that bacteria take and subsist on. Certain bacteria have an enzymatic mechanism based on a different genetic predisposition that allows them to take up these particular glycans. And we call it this polysaccharide utilization pathways. And you can see in case of MDCF2 at the bottom, there was more of galactan, arabinan, xylan, and mannan. And what are the components of the MDCF2 that are important sources? And we see that it was green banana, it was soybean powder, and then it was the chickpea. These three were the more important components. On the other hand, if you look at RUSF, there's some improvement, and this is attributed to lentil, little bit to rice, but no effect whatsoever of milk in, achieving the effect of the glycans, arabinan, xylan, and mannan. We then went on to look at what happens, and here you can see that we compared children who were in the RUSF group with children who received MDCF2. You can see that there were certain bacteria who were more in the group that received MDCF2. And these are the bacteria, these are the members of the gut microbiome that are more associated with increased presence of the important glycans, arabinan, fucose, and other things. And they were all associated with weight for length Z-score. And what are these bacteria? At the bottom of this slide, you can see the different clades, BG0018, BG means Bangladesh, and these are Prevotella copri, different clades. And of course, we have two clades of bacteroides longum. On the other hand, we then tried to look at what happens to children with differing levels of improvement. Some may have improved less, some may have improved more. Again, we saw a difference. In children who improved more in response to MDCF2, more of them had this Prevotella copri as well as Bifidobacterium longum. So this is the results that we have. And today, as I speak to you, we have other trials now running in Bangladesh, one in Kurigram, one in Dhaka. We have trials running in different parts of the world, in India, in Pakistan, in sub-Saharan Africa, notably in Tanzania and in Mali. And very soon we are going to start a trial in Niger. And for the Niger trial, we are going to airship all the product made in Bangladesh. Last year, the Economist, they looked at it, and I was surprised that they published a 2-page feature on the work that was done at icddr. And they concluded by saying that for many malnourished children in the future, it is microbiota-directed food that could make all the difference. So now what it remains is that we need to promote it and implement it in other parts of the world. And of course, this has to be based on the results of the ongoing trials. Again, coming back to the health systems, it's the health system that needs reform. Without that, no matter how good products you have, you can do very little to control the huge rates of childhood malnutrition. I haven't spoken about maternal undernutrition. That's again a huge issue, and we are working a lot on that. It's the mindset that needs resetting. The question is, are we optimistic? Can this be sorted out? And I think, yes, we are optimistic. We can do it. And this is a work in progress. And we are doing a lot, first of all, to create awareness. And this awareness is at all sectors. People in Bangladesh, the policymakers, the people who run pediatrics, they are not at all concerned about the high rates of malnutrition. This is where we need the awareness. The press, the social media, we are now having a very elegant program of educating doctors, medical students. When I was a medical student in Bangladesh, I had to, learn how to diagnose mitral stenosis by listening to the murmurs. But, hardly we tapped into the realms of childhood malnutrition, which is a national problem. We think that it is time that we take this as an opportunity and, educate not just medical students, but also nursing students and nurses. We have recently obtained government approval to test the Swarnali in the mainstream population. By the way, Swarnali is a Bangla term, and this means golden. And the idea is to give back the child suffering from severe wasting the golden days that he or she has lost. And finally, based on the work that we are going to do in the mainstream population, we are then going to advocate for a community-based program in the country. And already we have gone a bit further by having it improved in the operational plan of the Ministry of Health of the government of Bangladesh. So to summarize, ladies and gentlemen, I thought that I should speak about malnutrition because this is still a formidable problem in Bangladesh. Rates are unacceptably high. The awareness about childhood malnutrition in such a country is appallingly poor. And we have food price hike. We have poor gestational weight gain. I didn't talk about that. We have suboptimal hygiene contributing to malnutrition, to enteropathy, which is again something that is so common. For time constraints, I didn't talk about it. And now we have new products that have been developed locally and are being produced locally. But finally, we need to reorganize the health system so that it is able to take care of children suffering from malnutrition. I would like to thank you once again for coming here today and for giving me the opportunity. This is where some of my colleagues, they are there, standing in front of the main building of icddr. Most of the work that I have shared with you was supported by the Bill and Melinda Gates Foundation, now the Gates Foundation, and of course by the governments of Canada and Bangladesh. With that, thank you very much.
Handheld. Yeah. And then questions.
Thank you for the excellent talk and very important work. So I was wondering, I'm hoping that this microbiota-directed food will be a policy sometime. So when this will be a policy, what will be the approach to find those children whom you need to intervene?
For this to be incorporated into policy, we have to take a number of steps. And these steps include completion of the trials that are ongoing. And only then, I think the government of Bangladesh will embrace it. But for now, what we are trying to do, we have Swarnali, the local RUTF. This has been recognized by the government of Bangladesh. We want to have it implemented in the mainstream population. When the time will be ripe, we think that we are going to replace this Swarnali with the microbiome-directed food. It may so happen, right now we are thinking about the glycans. I told you that is the glycans that are important. We are now trying to think about having synthetic glycans. Maybe there will be a time when we can have a B version of Swarnali, where we will lace the RUTF with these glycans. So this will be a super Swarnali. So these are all aspirations now, but this is the process that we think we are going to follow.
Tahmeed, thank you for this talk. You are upending child feeding for malnutrition, especially lacking milk in this diet, which has been the mainstay for child feeding for decades. Um, you mentioned metabolomic profiles that are changing. Have you seen anything on the proteomic side, on the plasma proteome, in terms of protein indicators that may be useful biomarkers for how well a child is recovering?
Thank you very much, Dr. West. And again, thank you for the huge work that you have done in Bangladesh. I failed to recognize that at the beginning of my talk. Thank you. Yes, there's a huge amount of work that we are doing on proteomics. We have been able to identify specific plasma proteins that are more expressed in children who receive this MDCF2 therapy. And we have seen that some of these plasma proteins are responsible for development of the brain, for development of the long bones, and as I mentioned, also for immunocompetence. Right now, with some of these specific plasma proteins, we are trying to see if we can have, kits, diagnostic kits, by which we can identify children who are at risk of suffering from these conditions.
Hamid, I'm going to ask a question really
Yeah.
quick. Just in terms of operationalizing this and scaling it to the community, with ORS, I don't know if I don't know what proportion of children being treated with ORS are getting actually packaged ORS versus mothers combining sugar salt formulation at home and making ORS. And I just wonder, given that all of the components are readily available by definition and locally available, is there a thought that this should be packaged, or that this could be something that mothers could be instructed to produce?
That's a very important and interesting question. So when we went on to work in Africa as part of the Nutrimem trial, we talked with colleagues in East Africa and West Africa. Colleagues in East Africa, they told us that, no, our people, they want to have food that they would themselves prepare. So we then had to develop sachets, small sachets, with all these components separate, and then the mother would, reconstitute at home. This is what they wanted, and we had to listen to them. On the other hand, when we discussed this with folks in Burkina Faso, in Niger, they told exactly the opposite thing. They said, no, this homemade thing will never work. They want sachets because they are used to this. So whatever you do, you have to come up with sachets. Okay? So I don't know what would be the right answer, but in case of ORS, Bangladesh started with this homemade preparation, but now that seems to have phased out. ORS is available, and people are used to reconstitute the ORS at home. Again, having bad and good things, that's another discussion. Thank you.
Thanks so much, Tahmeed, for this wonderful talk. I have two different questions. One is related to your kind of emphasis on health systems. And in many contexts, in low middle income countries, the experience we have is that nutrition is really not integrated within health systems and the way health systems is administered and implemented. And so I was wondering if you had any reflection on that, as well as thinking about other platforms through which nutrition can be delivered. Nutrition has also been an orphan in terms of having its own platform. There are some countries which have had it, like the ICDS program in India. In Bangladesh, the BINP was one of that experiment, but then it disintegrated. So that's, I just wanted you to talk a little bit about that. And even within the context of antenatal care, we see a lot of emphasis on health, but not nutrition, which is so, it needs to be integrated. My second question is related to green bananas. And I'm wondering if we know enough. So Carlito's lab does a lot of work in just on understanding these ingredients or the composition of foods. And I'm wondering if there are other foods such as the green banana, which have the glycan properties that can also be explored in different environments. Thank you.
Thank you so much, Parul. And again, thank you for your work in Bangladesh. You're also doing seminal work with icddr colleagues. Thank you for that. For the first question, I mean, it's a struggle. If you look at the annual budget for health and find out what is being spent on nutrition for a country with such huge rates of malnutrition, this minuscule. And again, within this small portion, I tried to look at what goes to nutrition-specific interventions, what goes to nutrition-sensitive interventions. Bulk of the budget, whatever we have, goes to nutrition-sensitive interventions. For those of you who don't know, these includes agriculture, these includes water sanitation hygiene, these includes family planning, so on and so forth. So you can imagine you need nutrition-specific interventions, for example, breastfeeding, vitamin A, micronutrient supplementation, treatment of acute malnutrition. For this, a very small proportion of the very small pie that is left. So I think this has to improve. And for this, hopefully we'll have a new parliament. We don't know when, but we think that that will be the time when we'll be able to approach them so that there's more spending specifically on nutrition. You're absolutely right. We need a platform. Right now, there is no platform, as I've tried to show in my first few slides. During the days of the Bangladesh Integrated Nutrition Project, which ultimately scaled up into the National Nutrition Project, we found it to be very good. At least people, mothers would come to a place, they would discuss amongst themselves. Mothers, they have a lot of anxiety, depressive symptoms. When they come to a place, they discuss, they chat. That improves the situation, apart from improving the nutritional status for many of the other interventions. I think if possible, we should have something like that, but that would be a luxury. At that time, that was a credit coming from the World Bank. That was a loan that the country had to repay. I don't think that we can afford that much of luxury now. But what I believe is that if the community clinics in some form or other, if they are made to be revitalized, and if we have somebody who can take care of this nutrition, I think that can be a way out to solving this problem.
And the green banana.
Oh, alternative to green banana. Oh, I remember. Yes. We have looked at other food ingredients. We have experimented number of such ingredients. The one next to green banana is sweet potato. So that holds substantial promise, but we need some more work to do on this and then the clinical trials. And of course, Carlito Labrilla happens to be the expert in this field. At UC Davis, it is he who has the lab that can do all these types of very sophisticated analysis.
Thank you, Tahmeed. Wonderful talk and wonderful to hear about Bangladesh and the tremendous progress that has been made. As you showed, the improvements in terms of decreasing stunting and little blip up in the end on wasting, but certainly decreases. And Bangladesh has had such economic development over the past decades. So I guess what I'm asking is, I was distressed to see you visiting a clinic that was completely closed. So it's not only are they not providing nutrition to children, they're not providing, as Parul said, the antenatal care or the other health care that children are needing. Is it, what I'm asking is, the politicians of Bangladesh should be very, very proud of the progress that has been made. Is it possible to marshal that progress into continuing to have it with the health system and build nutrition into that? So a frame that how wonderful things have been over this time, and in order to meet the SDGs and to continue forward, that the momentum is there, the skills are there, and what can we do to make it go forth? And meanwhile, add nutrition as part of that as well.
Thank you very much for your wonderful comment and question. Recently, we did an analysis exactly looking at what you have mentioned. Is it development? Is it something else that had led to the reduction in stunting from 54% to 24% today? 24% is still very high. But where we went from 54 from 22, 24% is a huge, huge reduction. The analysis that we did exactly shows what you have just said. It's development that has, resulted in this. So I think development is very important, but, we could have done even better. We had better health systems, even with this. And that's exactly what we need to do now. And what has happened over the past several years in this country, and I think you know about it, all the turmoil, the economic turndown, the flight of capital, all these things, these have an utterly negative impact, on both child and maternal undernutrition. I mentioned during my talk that already we are seeing indications of that. Wasting rate has increased quite a lot, so that we might be close to the WHO threshold of an emergency cutoff of 15%. So we really need good health systems, and hopefully we can revive some of the good things. But again, it's health systems, and specifically it's good governance. That is not just there. Government has put in resources in many places, but the resources are not being utilized properly. This is what I see when I go and visit places, unfortunately.
Thank you. I will just reiterate one thing that Tahmeed said, which is the importance of good governance. I do want to. Amen. I do want to just note also that a number of us, I believe 6 of us from Hopkins, are traveling to Dhaka next week, and in 2 weeks, at the invitation, and I should note, I think importantly, I would say among this group, and at the expense of icddr, at their invitation to come and talk about further collaborative engagement with our institution. And I think it's a remarkable time in so many ways, but it's a remarkable time to sort of reimagine partnerships. And I think Tahmeed and Dr. Ahmed's sort of kind invitation being extended from a partner to sort of host us in this manner, I think is very symbolic of sort of how we're entering a very different world. And I think a world that offers tremendous new opportunities for engagement. And so this is an amazing history that we've heard about of partnership that many of you have been part of. And I really, truly believe that the next 50 years will bring even further gains. So thank you very much. Do you want to, sorry, last word to you.
Thank you, Dr. Walson. Since this is my first visit to this prestigious institution, and I have all my previous directors and my leaders, mentors here in this audience, many of you are here, I want to take the opportunity of thanking Johns Hopkins School of Public Health for what you have done. This has been a legacy of work between the two institutions. And I want to take the opportunity again of inviting you to come and to work with our colleagues, junior colleagues in particular. And we have huge data sets, we have projects, And you can work with our colleagues in all these projects, you know. And please, warm welcome. Thank you.
Thank you. And thank you for the wonderful talk. Thank you. Thank you all so much. I'm sure we can stay for a few minutes if people have further questions, but thank you all for coming. Thank you.
33. Yeah.